Hi, this is Tom Blücher with Inside Cardiology. Today we talk about sex. And if I mean sex, I mean biological sex, males and females. And obviously they differ in cardiovascular disease. As you see on the slide, females have more HFpEF rather than HFrEF. They have Takotsubo. They have, of course, pregnancy-associated diseases. And they have one Cinderella that's hardly discussed until recently, and this is spontaneous coronary dissection, or SCAD. And let's talk about SCAD. First of all, you can see it's an acute coronary syndrome. We have different forms of acute coronary syndromes listed here on this slide, from plaque rupture, erosion, spasm, embolus, very rare. Myocarditis can, of course, mimic an acute coronary syndrome. Takotsubo presents like an acute coronary syndrome. And, of course, coronary artery dissection is a classical presentation with ST segment elevations, ST segment changes, T inversions, and, of course, pain. Good. So what is the characteristic of coronary artery dissection? You can see here the OCT on the left, where you see it's a false lumen and the true lumen. In the false lumen, there's usually thrombus, and mostly these are females. The vast majority, over 90%, are females. They are younger. They're usually fertile, contrary to Takotsubo, that's post-menopausal in nature. They do have more hypertension than average. They have often fibromuscular dysplasia. They can have pregnancy. Very bad form of SCAD is during pregnancy. They have stress as a trigger, very much like Takotsubo, but it can also be hypertension, strenuous exercise. So it's a bit broader. Also physical and psychological triggers, very much like Takotsubo. And of course, this is the angiographic presentation. You see with the arrows that there's a thinning of the vessel. Sometimes you do see the false and the true lumen. Maybe sometimes you see the dissection membrane, but the angiographic presentation is more difficult than OCT that I showed you a minute ago. There are basically three types. Type 1 involves multiple lumen and contrast staining in the arterial wall. Type 2 involves stenosis of the arteries with an abrupt change in diameter, as we see here in the mid-LAD. And type 3 looks very much like atherosclerosis. So it can be difficult to reach a decision. Now, which vessels are primarily affected? We can see here it is mainly the left anterior descending coronary artery, the LAD. And when we look at the different types, you can see TIMI flow in the different colors. Interestingly, most patients still have TIMI3 flow, so abrupt closure and very severe impairment of coronary flow with TIMI1 or 2 is not so common. Luckily, and we'll come back to that when we talk about the management of it. Here you see different forms. Here is a diagonal branch where you can see in panel A the dissection membrane, then this more diffuse tubular form in panel B and C, and then panel D very much looks like an atherosclerotic LAD. It's very difficult to discern that from the angiographic picture, but if it's a young person that still menstruates, is female, you must be suspicious of that. And of course, in ENF we have other presentations just to train your eye. And here is again the intracoronary imaging of SCAD with IVUS and OCT. In panel A you see IVUS, and with the arrows this shows actually the thrombus that's in the false lumen in general, and in OCT you can see the membrane, and in the 3D reconstruction you see the dissection in black. And here of course you see on the inset that I show you here, you can see the enlarged OCT with the true lumen being very small and the false lumen being very big, and there's the rupture in the middle of the membrane here. But you can see that it's very difficult for an operator to be sure that you're in the true lumen, because usually the true lumen is much smaller than the false lumen. And this is further shown here in a pathology specimen. You can see here again the true lumen and the thrombus in the false lumen. And so to be sure to be in the right spot when you want to do a procedure is challenging indeed. Okay, so what should we do with these patients? Now, of course, in principle, when somebody presents with pain, ST segment changes, troponin, PCI is the next step. But is PCI the right approach in SCAT? You can see here an example of a SCAT or a dissection in the first branch of the circumflex in panel A. Then a balloon is inserted. The wire went well into the true lumen, but you can see then with the arrow the shift of the thrombus that led to a stenosis in the proximal part of it. So thrombus shifting or shift of hematoma is a real problem. So the concerns with PCI and SCAT are that the guide wire would end up in the false lumen, that you actually stent the false lumen and completely occlude the coronary artery and induce a huge STEMI, and of course the hematoma shift as shown in these angiograms. So Jacqueline Saw has published some years ago the Canadian SCAT cohort study, and they looked at in-hospital and 30-day outcomes. And here you see that the vast majority was handled conservatively. 86.4% of the 750 SCATs were handled conservatively, because in general operators are a bit shy to approach these lesions because of the fear to end up in the false lumen and other aspects. And then some received fibrinolysis, very few, and only about 1 in 10 received a PCI, and the CABG was even less frequent. Now, when they looked at the outcome, and the outcome really reflects primarily the conservative approach, because it was the vast majority, as I showed you. You can see in the first 30 days, the time period that typically surgeons give, but it's also relevant here. You see that cumulative MACE incidence is around 8%. So 1 in 12 patients do have an event, which of course can be then a reinfarction. It can of course be also death. In fact, in ATVB shortly there will be a paper of patients that had a fatal outcome with SCAT, and they are mainly females, and particularly bad outcomes are noted in those that have SCAT before, during, and after pregnancy, delivery rather than pregnancy. Should we give antiplatelet therapy? This is a registry with all the biases that may be involved. This DISCO registry by the DISCO collaborators, and here you see that in fact they compared those receiving dual antiplatelet therapy. This was 2/3 of this around 200 patients. 1/3 got single antiplatelet therapy or SAPT. And what they paradoxically found, as shown in the inset on the top and the lower left, is that those with SAPT had a higher incidence of MACE. Difficult to explain. One possibility would be that it might be good not to inhibit platelets too much, because maybe the thrombus will grow and make things worse. So maybe there is a sweet spot on antithrombotic therapy, not too much, not too little, not too much to get bleeding, not too little to actually let the thrombus grow. And you see on the right, overall MACE was markedly higher, actually 2/3 higher. the single antiplatelet therapy. Overall death was relatively rare. Reinfarction was also more common with DAPT, which is paradoxical as our urgent PCI. However, of course, this is a registry. There is now a trial ongoing because there may be decision biases by the treating physicians, and we cannot exclude that. So in summary, SCAT is an unrecognized presentation of an acute coronary syndrome. These patients present alike, like a STEMI or non-STEMI, with pain, ST segment changes, T-wave inversions. They have troponin, obviously, very often. They're typically below 65 years of age, mostly in the fertile age. They can be around delivery, during pregnancy and after delivery. And they often also have fibromuscular dysplasia. That's why when they have hypertension, you should look at the renal artery stenosis in these patients. The trigger can be psychological or physical in nature, and therefore in females in the fertile age where infarction is relatively rare, with such triggers, don't forget to think of SCAT. And if it's a SCAT, be careful with the injection of contrast during angiography, not to expand the dissection. Think about PCI twice because conservative management seems to have reasonable results, and consider to reinvestigate the patients when they cool down to see how the coronary anatomy is, and then at this point the PCI might be an option. Whether we should give them dual antiplatelet therapy or only SAPT remains controversial. At this point, the data would suggest that single antiplatelet therapy would be enough, but it's a field for research. So if you're interested, collect patients, do trials, do registries so that we get better evidence even than we have today. It's an interesting disease, so don't forget it. Thank you.